Hello, this is Dr. Jeffrey Miller from Baltimore, Maryland. This is part 3 of a 5-part series on alveolar focused orthodontics, visualization of limitations of orthodontic tooth movement through cone beam CT. I'm Jeffrey Miller. I graduated from Towson University, got my dental education at University of Maryland, received my orthodontic certificate from State University of New York at Buffalo, my board certification in 1991. I've been in private practice in the Maryland area for over 33 years. I'm a member of the Golden Circle of Excellence, and I speak on cone beam CT topics related to orthodontics. Today I'd like to talk about orthodontic dehiscence pattern. Orthodontic dehiscence pattern is defined as a generalized dehiscence pattern associated with the orthodontic overexpansion or constriction of the dental arch that is not compatible with the underlying bone anatomy. In other words, when we talk about orthodontic dehiscence pattern, we're talking about a tooth that is positioned with disregard of the anatomy of the alveolar process. The anatomy of the alveolar process varies, and as orthodontists, we need to be mindful of what that anatomy looks like. When we talk about orthodontic dehiscence pattern, it's the magnitude and the generalization of the dehiscence pattern that's associated with orthodontic treatment, or normally in the case of overexpanded dental arches. I would also further go on and say that it's an unnatural phenomenon. You wouldn't see this type of situation occur naturally in most cases. This would be these orthodontic dehiscence pattern is unique to orthodontic treatment. This is an axial view of a patient with orthodontic dehiscence pattern. This was a transfer patient came in to our practice. She had been being treated by an orthodontist who used an expansion technique to avoid extraction of teeth. And you can see from the shape of the pulp chambers, and this is a slice 3D reconstruction, but a slice taken into the roots. These are the roots. There's no clinical crowns here. And you can see how much dehiscence has occurred for this patient. Orthodontic dehiscence pattern in this particular case, if you compare it to a patient, these 3Ds were set at the exact same settings and were taken with the same exact settings. You can see the difference. Now, typically the 3D reconstruction is not diagnostic. It just gives you an idea or a feel for what's going on a global scale. Orthodontic dehiscence pattern can only be diagnosed 2 ways, either through cone beam CT, as in the case here, or after the patient starts to develop problems by direct visualization through either surgery or tissue dehiscence. It cannot be diagnosed properly using a pan-encephalometric X-ray. This is a 17-year-old patient that a colleague of mine was kind enough to share. He treated this case non-extraction using an expansion technique. And let's take a look at what happened. Okay, here he is. This is showing some of the mechanics he's using. Starting to get things lined up. You can see this is a 6-month visit. Also take a look, here it is at 9 months. Take a look at the tissue associated with some of these teeth as they're expanding. Here's at 13 months. At 29 months, he's pretty much done. Here's his finished result. Before and after. Clinically, the photos look, great. I don't know what's going on here, but you see how this tissue's red. You see something's going on here. I'm not sure what. It's changed to his profile, which looks pretty much unchanged. Then here's his smile. Okay, so patient shows up. At the time this case was finished, the orthodontist that did the treatment did not have cone beam CT technology. He did get it at some point, and this cone beam on this patient was taken 3 years post-active orthodontic treatment. So it took a cone beam. This is the reconstructed pan and ceph of that patient. You look at the ceph and you know, if you look at the cone beam first and then look at the ceph is going to look different than the other way around. Okay, so here is a 3D reconstruction. You can kind of get an idea. I adjusted this to make it correspond with the individual slices as much as possible. And you can see where these roots are. And you can also see where did the space come from to align the teeth. And it came from, you know, just really overexpanding the intercanine or intercuspid width. Take a slice. It's important to know where the slice is taken. If we take a slice down this between halfway down through the roots, you can see here where these slices are taken and the corresponding images. These are approximately 1 millimeter apart. So these images here on the right are 1 millimeter apart. Okay, so here is the axial view of the lower arch taken about halfway down the root. And you can see that from the way these teeth are shaped and the pulp chamber, obviously they're very, very much flared out. Here's what he started with. Here's his 3 years post-active orthodontic treatment. Here's the finished result. And that intercuspid distance is where they got to most of the correction. All right, so let's take a look at how much expansion was done within those cuspids. Okay, so here I'm compensating for the position of the cuspids because I want to take the slice, you know, either perpendicular or parallel to the long axis of the facial axis of the tooth. Okay. And what I'm going to do is, instead of taking the slice down through the cuspid, because there's really not much bone on the facial surface of the cuspid, I'm going to just take a slice right through the interseptal bone. I want to see where the interseptal bone is. And here you can see, just as mesial to the lower left cuspid, you can see the outline of the interseptal bone. What I did was I put the hash mark or the X right on the cortical plate here, and then I slid the slice over to the center of this cuspid. And you can see here the interseptal bone ends about 5.77 millimeters from the leading edge of that cuspid root. It would have been better if I had a pre-treatment cone beam CT, but that didn't exist for this patient. Periodontists use this measurement quite a bit to determine if a graft will be successful. The closer this interceptal bone is to the leading edge or the facial edge of the root of the tooth is a predictor in terms of how whether a graft is stable or will last. When you take a look at if you take a look at this measurement, this means that that patient had, 10 or 11 millimeters of intercuspid expansion to accommodate for this crowding, and that's probably not that far off. If we look at the bone distal to the cuspid, it's about 3.71 millimeters, or about just under 4 millimeters. And that's still pretty consistent with what we saw clinically. With the upper cuspids, you see where we're taking the slice right between the cuspid and the lateral incisor. Here's the bone, and it's about 4.39, which means it's about 8 to 9 millimeters of intercuspid expansion to align for the crowning. That's probably not too far off. I did go as far as send this cone beam over to beam readers to have an oral maxillofacial radiologist read that cone beam, and he came up with conclusions that teeth 6 to 11 and 21 from 28 possible bone loss of buccal bone. Also, he notes here that this is consistent with orthodontic dehiscence pattern. They're always going to mention that the very thin bone may not appear on the cone beam CT image. and I think that's fair. But does that make the clinical significance in what was done here? I mean, whether you think this was the right way to treat this case or not, I think if you evaluate this case using a PAN and a Ceph, you're going to come up with a completely different conclusion than if you use a cone beam CT to evaluate your final results. Thanks for listening. I hope you enjoyed the short presentation. If you have any questions, you can contact me at drmiller@orthodonticassociates.com. Thank you very much.